So again, 1 teaspoon is equal to 5 milliliters. 1 tablespoon is equal to, I know, Natalie, is equal to 15 milliliters. So how many teaspoons in a tablespoon? If 1 teaspoon is equal to 5 milliliters and 1 tablespoon is equal to 15 milliliters. Yep. So there are 3 teaspoons in 1 tablespoon. That one you're going to want to remember eventually too. Well, let's just say that. Well, you want to remember that. 3 teaspoons per tablespoon. And then 1 ounce is equal to 30 milliliters. And you can actually kind of see it here on the cup. But if you look over here, you're also going to see that 2 tablespoons is equal to 30 milliliters. So 1 ounce, 2 tablespoons, 30 milliliters. Same measurement. In theory. The problem with household utensils, like using an actual spoon, they're not precisely calibrated. So you need to make sure you're instructing your patients and their families to use specially calibrated droppers, measuring teaspoons, and cups. So here's a comparison of metric and household liquid measurements. About 1 milliliter is equal to about a drop. 5 milliliters equal to about a teaspoon. But again, these aren't all calibrated. Okay. So we've got 1 tablespoon is half an ounce. So that's 15 milliliters. 2 tablespoons, 1 ounce, 30 milliliters. 1 measuring cup is equal to 8 ounces or 240 milliliters. 1 pint equals 16 ounces or 500 milliliters. 1 quart equals 32 ounces or 1,000 milliliters or 1 liter. And then you have 1 gallon equals 4 quarts or 4 liters. Again, this goes into pounds to kilos. So oftentimes you guys are going to be doing this a lot. I mean, I can't even emphasize how much you're going to be doing this. So how many kilograms are equal to 120 pounds? So we kind of already did this one already, but you can plug in any numbers, but you're going to be converting a lot. You have a patient who weighs 170 pounds and they need their medication dosed in kilograms. Rounded to the nearest tenth. Patient's 170 pounds, and they're going to need we need their weight in kilograms to figure their medication dose. How many kilograms do they weigh rounded to the nearest tenth? Good job, Shanae. Yep, it's 77.3 or 77.272727. Anyways, so yes, it would be 77.3. So some errors in the clinical setting. Giving 10 milliliters of a liquid instead of 10 milligrams. Converting 1 gram to 100 milligrams instead of 1,000. That's a 10-fold error, guys. Giving 20 milligrams instead of 200 milligrams for a 0.2 gram order. Again, another 10-fold error. Reading 100U as 1,000 because units was not spelled out or a space was not left between the number and the U, or the U was closed and looked like a 0. Again, a 10-fold overdose. That's why we don't use the abbreviation U, you write out units. Reading 7.5 milligrams as 75 because the decimal wasn't seen. Or reading 100 milliequivalents as 100 milligram, which are not the same measurement. Keep in mind, if you see milliequivalents, that's the amount of medication solute. So some key points for metric. Metric system uses Arabic numerals and decimals. So by Arabic, we're talking kind of like Roman. So 1, 2, 3, 4, 5. Okay. In the metric system, the only measurement in weight is a gram. You might have a kilogram or milligram, but it will always be in a gram. Use only approved abbreviations. Liquids are measured in some kind of liter, so milliliter or liter. Household measurements have many implications in discharge. Again, remember, kitchen utensils are not calibrated. Whenever possible, send the patient home with something to help them measure. Most of the time, the pharmacist will provide that. A teaspoon, if you see a written order for a teaspoon, it's calibrated to 5 milliliters. A tablespoon is 3 teaspoons or 15 milliliters or half a 30 milliliter medication cup. An ounce is 30 milliliters or 2 tablespoons. Honestly, Adriana, I'm not sure. I am assuming they are probably under, because they're just not calibrated, and that's why we shouldn't use them. If you really wanted to experiment, get one of the graduated medicine cups or something, and then get a teaspoon or tablespoonful of liquid, and then put it in there and see where it measures. And also, last but not least, also do not substitute. Yes, do not substitute. Do not substitute a shot glass for ounce cups. Okay. Use a measuring cup. Kind of like use a cocktail stick. Couldn't help myself. Well, I probably could have, but I didn't want to. Use a measuring cup. Anyways, so milliliters preferred metric unit for liquids, not cc, which is cubic centimeter. They are not the same. Do not interchange them. You will not be using cc or cubic centimeter. You will only be using milliliter. Liters are used by clinical agencies. It's a little bit more than a quart. So 1,000 milliliters or 1 liter is equal to 960 milliliters in a quart. So watch it. If you're writing 2.2 pounds without a space, it can be misread as 2.21. So you want to make sure you kind of leave a space. I think it's outdated, Veronica, and it's not very exact. I don't know. We've gone basically metric, so we've gone to the liter, milliliter. Always think in metric, but if you have an order that is not clear, call the pharmacy, call the prescriber. If you can't read it, make sure you're clarifying, because you do not want to make a mistake. Okay, abbreviation errors. So milliliter is always, yeah. Always a lowercase m, capital L. You don't want to do mLs. You don't want to do cc or cc's. Grams, only a G, lowercase g. No uppercase G, no GM, no GMS, no GS. Okay. Micrograms are always mcg. Okay. What you see here, these little U looking things, the long leg on the front, that is actually how you write micro in like chemistry and very scientific, but not in nursing. You're going to write MCG. Milligram is MG, not MGM. It's not a casino or a movie producing studio, not MGMS. Unit, you're going to write it out. You're going to write out the word unit. And then you'll see things measured like vitamins. A lot of times are measured in international units. Do not abbreviate IU. That's the way I was taught to use IU. It's no longer allowed. Same with U for units. You have to write out international units. Okay. So let's do some math problems. Actually, do you guys want to take a quick break? I kind of figured that would be the case. So sharing my screen. So why don't we then take a 10-minute break? So please be back at 1:40 and we'll do some math. Oh, they should be. I will double check that, Tanya. Thank you for bringing that up. Oh, we need to talk about the paper too. The case study. Oops. Under the week 3 readings. Tanya, they should be available. Are you getting a broken link again?
I will look again right now.
Okay. There was one I know there was an issue on and I thought I had fixed it, but let me know.
I'm getting access denied on the metric units and conversions.
Okay.
This is Adriana. I also wasn't able to like upload or download them for notes.
Choose 3. Okay. Tanya, was there any of the other ones you can't access?
I could not access the dimensional analysis student copy. I'll try the pharmacology students. It looks like I can get into the lifespan considerations, the chapter 3 pharmacology, and the chapter 5. I can get into those.
Okay.
So the nurse, the math, the meds are the ones that I'm having.
This is what happens when you import everything.
Oh no.
Because I could take it from the previous term and get in there. Okay, so I just literally fixed them. So if you want to like go out of the module and go back in again or whatever and see if that works.
Okay.
If that doesn't, let me know.
I can see them both okay now. Thank you.
Yay! Okay, thank you, Adriana. I will look at that next. It's all fun and games till stuff doesn't work. Okay, Adriana, which chapter 11 is that in the which module is that in? Never mind, I found it. Make sure you let me know what module that way I go to the right one. No, that's okay. Okay, guys, I'm gonna step away for a bit because I have to use the ladies' room and get some more water. And I'll be back. That's okay, Adriana. I actually wrote them down. So I'll be able to check those later. All right, so we're going to get back to started. So we're in chapter 3 of the drug book, guys. If you can pull it up, great. So what I want you to do is, what is the name and the abbreviation? Let me see. Actually, I want to do this. See if I can get whiteboard up. Oops, not that one. Share. And if you guys want to use, unmute and say it, or if you want to type it, whatever you want to do. So, what is the name and the abbreviation for now it's saying I can't display my whiteboard. Yep. Okay. Let me start over. Whoops. What is the name and the abbreviation? Yes, Natalie. It is, yes, correct. Milli. M. So it's 1/1000. So when you're looking at a decimal point, I'm going really far. Okay. So this is 10, so that's deci. This is 100, so that's centi. This is 1,000, so that's milli. So if you want to determine if something's how many milligrams something is, so if you have 4 grams and you want to know your milligrams, okay, I'm going to do something we're not supposed to do. Okay, so then you're going to move it which direction, guys? And we want milligrams. So
to the left.
well, we know 1,000 milligrams is equal to 1 gram, right? Yep, to the right. Sean got to the right. Yep, it's to the right. I know it seems weird because this is milligrams. Because this will equal 4,000. milligrams. All right, so if we're talking about centi, what's the abbreviation for centi? Yep, C. Right. So I recommend, guys, that you work the rapid practice problems in chapter 3. They're extremely useful. Okay. And if we have time towards the end here, we'll go over some more of the math stuff. So let's do, I'm kind of skipping weird, I know, but I'm kind of trying to segue where things go better. So we're going to actually go to chapter 5 in your Pharm book. So the medication errors, because we ended the last chapter 3. Yep. So there's another one to keep in mind, guys. There are some C's and little c versus big C. So uppercase versus lowercase does make a difference. So because we just talking about some medication errors at the end of the chapter 3 for the drug book or the math book, I'm going to go ahead and move on to the medication errors. So compare the following terms: adverse reaction, adverse drug reaction, or adverse drug event. Be able to describe commonly encountered medication errors. Make sure you develop a framework to prevent them. Identify potential physical and emotional consequences of a medication error. Yes, chapter 5. Impact of culture and age, ethical dilemmas, agencies, and possible consequences. So, adverse drug events. The Institute of Medicine, or IOM, actually produced a report called "To Err is Human." And it really actually brought about medication errors to the public. So, in number of patient deaths from medical errors range from 44,000 all the way up to 98,000 annually, and preventable errors were responsible for about 7,000 deaths per year. In 2006, medical errors harmed at least 1.5 million people and cost over $4 billion with a B dollars. They did a follow-up study in 2010, and it didn't show any changes. So the key to preventing errors is to recognize that reporting an error shouldn't be punitive towards the person reporting it. Excuse me. In other words, excuse me, if you make a medical error or a medication error, it shouldn't be used as a punishment for you. It should be a learning, and to help figure out where a breakdown was or what happened. So the follow-up report actually noted that most errors occur as a breakdown in the medication use system as opposed to being the fault of an individual person. So when we talk about a just culture, it's where systematic review of an error is applied appropriately. Discipline is applied appropriately. So competent professionals still make mistakes. To err is human. We're all human. But it also acknowledges that sometimes we make bad shortcut habits. We take shortcuts. So QSIN, as we've talked about before, are continued to be integrated to help make you safer nurses. Medical errors can occur in all phases of healthcare delivery, and common types of errors can be things like misdiagnosis, patient misidentification, lack of patient monitoring, wrong site surgery, and then medication errors. So an adverse drug event is a very general term. It's all types of issues, problems related to medication. So it can be a medication error, it can be a bad drug reaction, something like that. So there are adverse drug reactions. There's two different types. You have your allergic reaction, which can be predictable if you know you have an allergy, and an idiosyncratic, which is completely unpredictable. Medication errors are a common cause of adverse outcomes, and they can have no significant effect to causing disability or death. So you want to make sure you identify and respond to and ultimately prevent medication errors, and may require an examination of the process. So we have the 10 rights of medication administration. Let's see. Jesus, give me one right. Good. Right dose. Sean, give me another right. Right person. Liara, give me another right. And you guys can unmute and say it if you'd rather. Time. Alondra, give me a right. Okay, right reason, indication. Good, good. Jeanette, give me a right. Documentation, good. Kristen, give me a right. We're halfway there.
Education.
Education, good. Very good. Shanae, give me a right. Good. Who haven't I picked on yet? Mercedes, give me a right. We got the right patient. So we have right dose, right person or patient, right time, right response. Good. That's a good one because that's one that gets forgetting. Oh my Lord. Send me back to English class. Forgotten a lot. Courtney. So we have the right dose, the right route, the right person, the right time, right indication, right documentation, right to refuse. We had right education, right response. Courtney, can you think of another one? That's all right. All right. Drug, medication, right. So where are we at, guys? How are we at? 8? Let's see. Right dose, right person, right time, right indication, right documentation, right to refuse, right patient. 7, 8, 9. Reason, routes, assessment. Yep, Isabel, education. I think Kristen actually said that one. So good, you guys. Exactly. Very important to remember those right. The first 5 are kind of easy if you went like who, what, when, where, why, and how. You know, who am I giving it to? The patient. Why am I giving it to the patient? What am I giving to the patient? You know, those kinds of things. So kind of look at it that way. So if you go into your book and you look at box 5-1, which is on page 65, assessment, yes, Veronica. You'll see some of the high alert drugs. So the adrenergic agonists, the classes and categories, some specific drugs, methotrexate, for non-oncological use. That one's actually used in rheumatology. In fact, my husband has psoriatic arthritis and he takes that. Concentrated electrolytes, and sterile water, even promethazine IV. So that's a place where you can look at some of your high alert medications and it'll give you names and categories. And then we're talking about safety and quality improvements in the QSIN box on that same page, page 65. Talks about drugs that sound similar. Paxil versus Plavix. Trazodone, tramadol, Humulin, Humalog, Depakote versus Depakote ER. So with Depakote there, you have a medication that it's the same medication, but one's extended release and one is not. So we have our adverse drug events. You have allergic reactions, which is the ARs. The IRs, which are idiosyncratic reactions. The AEs are adverse drug events. And then that whole big circle is adverse drug reactions. So you can see here, medication errors doesn't always mean an adverse drug reaction. Okay. So in 2006, IOM study estimated that some form of medication error resulted in harm to how many patients? Is it A, 400,000, B, 800,000, C, 1 million, or D, 1.5 million? So the answer is actually D as in dog, 1.5 million. Oh, medication errors, they're preventable. They're the most common cause of adverse healthcare outcomes. Drugs that are often involved include nervous system drugs, anticoagulants, chemo drugs, any high alert medications because of potential toxicity. And you have to be very careful when you're prescribing, dispensing, and administering these medications. So, things that you want to be aware of are look-alike, sound-alike drugs. And there are a couple ways you can either remember these. You can remember it as a salad. So they sound alike, look alike drugs, SALAD, salad, or LASA, look alike, sound alike. That one's easier for me. But if salad works better for you because you're food motivated, then sound alike, look alike drugs, there you are. So drugs that may sound similar when you say their names, or they look very similar when you write them out. So issues that can contribute. It can happen at many steps of the process. Half of all preventable drug events begin with an error at prescribing. So half of all preventable drug errors happen at the actual prescribing. The next most common is in administering, and then followed by dispensing and prescribing. Okay. Procuring has to do with the dosage forms and available financial resources. So if a patient can't afford their medication, that would be a breakdown in procuring their medication. So we're going to start with, so half happen at prescribing, then it goes to administering, then dispensing, and then transcribing. So if you have a question about your drug therapy for your patients, though, your pharmacist is by far probably one of the best people you can ever go to. So, organizational issues. Speak Up was actually created by the Joint Commission, or JACO, that encourages patients to be more active by speaking up and asking questions. That way they're able to learn about their illness and their care and advocate for their own safety. This also helps prevent things. What are you giving me? Oh, well, this is your XYZ medication. You know, by using computerized prescriber order entry and barcodes, that has reduced medication errors. Sometimes, though, technology doesn't get used the way it's supposed to. And then even with the computerized order entry, sometimes you can override an allergy or a drug interaction and potentially choose the wrong drug. And I have seen and heard about that happening, where a patient had a reaction because they didn't pay attention to the allergy alert that came up. One of the errors that are common for student nurses can be unusual dosing times. Excuse me. So you didn't dose them at the right time. Medication administration record issues. Failure to document doses given, so patients given extra doses. Administration of discontinued or help medications. Failure to review their record before you give a medication. Failure to monitor vital signs or labs. Giving oral medications, injectable. And then preparing multiple medications for multiple patients at a time. Never, ever, ever do that, guys. One patient at a time. And I will tell you this, we're not in clinicals right now, but when you go to clinicals, you may see a nurse getting multiple medications for a patient at a time. Please don't do that. Usually in the skilled nursing setting, which is where we do clinicals, you'll see that a lot. It is not right. It is not appropriate. And quite frankly, it frightens me because the risk of accidentally giving the wrong medication is way too high. And we have also sociologic factors, so communication, disruptive behaviors like intimidation, violence, inappropriate language, or inappropriate response to patient or staff needs. And then abbreviations. Again, we talked about the do not use abbreviations. If you look at page 67 of your book, there is a list there under the QSIN box, teamwork and collaboration. It's the use of abbreviations and which abbreviations should not be used. So types of errors. You could have no error, or the circumstances or events could have led to an error. So those are near misses. A medication error that doesn't cause harm, one that causes some harm, and then one that can result in death. So there's a lot of systems of checks and balances implemented to prevent medication errors. First, you got to have a legible order, and that has all the information that you need in order to do this. So if you aren't sure, call the doctor. Well, Veronica, we talked about nursing scope of practice and standards. If you think that the doctor is not correct in their medication, either the dose or something like that, what would you do? Yes, if you thought the doctor was incorrect.
Can I share something?
Absolutely.
This was maybe 6 months ago over at TMC. And it had to do with an anticoagulant. It was a new nurse. She questioned the doctor on the amount that was prescribed. And the doctor says, yes, that's what I want. Mm-hmm. And the patient went from being a walkie-talkie to dead within 24 hours.
Yep.
And I learned then, and I'll never forget, that we have the right to refuse a doctor's order. And I am so, I mean, I get teared up even thinking about this and certainly saying it, but I'm glad that happened, even though I'm not glad that a person died. But I'm glad that it happened at a time when, I'm studying nursing and it wasn't me, and that I had the opportunity to learn, third hand, but close enough for it to be personal, that we do have the absolute right to refuse to follow a doctor's order and tell the doctor, if that's really what you want, you come down and give that to them.
Absolutely. That's great. And here I'm saying that's great. It's not great that happened to this patient. But thank you for bringing that up, Kristen, because remember, guys, you're accountable. And so you question the doctor's order, you called the doctor, he said, give it anyway. So you have two choices. You can give it anyway and risk your patient's life, or you can call the doctor and say, I'm not going to give it. I don't think this is correct. You need to change it. You can talk to your charge nurse. If the doctor's like, no, that's what I want given, you can certainly refuse to give that medication because it is your license in the end that's on the line. And then you take it higher up. Hey, I called the doctor. He said this is what he wanted. I don't feel comfortable giving it. I'm not going to give it. And then it keeps escalating from there. But absolutely, guys, if you think that the doctor's wrong or you think they might have maybe written something incorrectly, call the doctor, call the provider. Don't call the pharmacist because they can't tell you what the doctor's thinking. Call the doctor and say, I don't think this is right. And if they still insist on it, like Kristen said that the physician did, and you're really thinking this isn't right, I don't want to give it, don't give it. No, Veronica, it doesn't have anything to do with when you touch the patient. If you give the patient that medication and you even hesitated and you called the doctor and said, oh, well, I don't think this is right. And he said, that's what I want, give it anyway. And you give it, just as in Kristen's incidents, the patient, if something happens, you're actually the responsible person. You could end up in front of the state board of nursing and potential to lose your license. Regarding knowing all these medications, we don't expect you guys to know them all. We expect you guys to learn how to use your resources. So things like your drug book, a lot of the Pyxis systems have information, your pharmacist, the nurses who are training you. If you have an app on your phone called Hippocrates or any other drug app on your phone that provides you information. And that's one thing. Especially when we get to clinicals or even when we're doing SIMs, guys, you're going to get a list of the patient's medications and you're going to have to make drug cards. So, but yeah, it totally is on your license. If you feel that this medication is not right and you check with the doctor and they say, yes, that's what I want, and you give it despite having checked with the doctor, it's still on you. You're supposed to be able to use your critical thinking skills to say, I don't feel good about this, so I'm not going to do it. And then escalate it to management. Okay. Thank you, Kristen, for sharing that. Always check the medication error 3 times before giving a drug. 3 times. Okay. And this, again, I need to edit these. I really need to go back through these. 10 rights. Make sure you're using your 10 rights. Other thing, medication errors. Make sure you're assessing your patient before, during, and after medication administration. Make sure you're using your 2 patient identifiers. That's what you're going to use all the time. If you do not draw the medication up or prepare it yourself, you do not give it. Ever. Okay? If I draw up 2 milligrams of morphine for Mr. Jones, and then I go, hey, Hayes, will you go give this medication for me? Hayes, what's your answer going to be? Very good. It should always be no. Never, ever, ever. That one especially because it's controlled, but never, ever, ever. If I mix a medication or do anything, I need to be the one to give it. You also want to keep verbal and telephone orders to an absolute minimum because a lot of errors occur there. So if you call up Dr. Jones and you say, Dr. Jones, your patient's running a temp of 102.3. Can I get an order for acetaminophen? And he says, yeah, sure. Give acetaminophen 1,000 milligrams every 6 hours PRN. And so you're going to say, okay, so that's acetaminophen 1,000 milligrams every 6 hours PRN. And that's what you're going to do. You're going to repeat it right back to clarify, just to be sure you said XYZ. If you need to, you can spell the drug name aloud. Other things like 40 or 14, 50 or 15. So make sure you say, okay, that's 15 milligrams, 1.5. And then make sure you're speaking slow and clear. And it always helps to put the indication. So lisinopril, 10 milligrams PO daily for hypertension. Don't assume anything about any items in an order. If I tell you lisinopril 10 milligrams daily, what's missing in that? Does anyone know? I mean, I know some of you guys aren't familiar with some of these meds, but no, I said daily. Route. Yep. Oral. It was lisinopril 10 milligrams daily, Sean. You're welcome. Or lisinopril 1 tab by mouth daily. What's missing? Lisinopril 1 tab by mouth daily. Yep. Exactly. Strength, dose, how much, however you want to put it. You're missing. You don't have anything. You don't know. Okay. So don't hesitate to question any order. When you doubt it, don't hesitate for a minute. Your patient's life is in your hands. If there is a written order and you cannot for the life of you read it, call the doctor. I'm sorry, Dr. Smith, I cannot read your handwriting. Okay. Trailing zeros, we talked about. Okay. You see how it can be misread as 10. If you don't put your dot dark enough, you can't tell. So it's best to just not even use trailing zeros. We're all on the same page, no trailing zeros. So if you write 10, I know it's 10 and not 10.0. Yes, Courtney, you can refuse and say, I don't want to give it. I'm not going to give it. I don't feel comfortable doing that. And if the charge nurse does it, that's on her license, not yours. Oh yeah, Veronica, you need to get over that because doctors are not always right and you need to advocate for your patient. You know what? I worked with a doctor when I worked with him when I was a nurse, and then I became a nurse practitioner. And I ended up working with him at his clinic. And I don't know if some of you guys know Dr. Mutter Pearl. If you know him, you're probably going, OMG. Dr. Mutter Pearl has thrown things at nurses. He has thrown charts at them. I tried my darndest to make sure he was nice to nurses. Some of the other nurses that would stand up to him did that. But yeah, no, I know they'll throw stuff at you. They'll yell at you, whatever. And you know what? You know what? You're then going to report them for abuse. Because no doctor should ever do that. I know. They're like that. Keep in mind, so when you do this, you're going to probably take abuse from the doctors. But oh well, oh my God, the surgeons, Shanae. Oof. But you know what? The surgeons, the reason why they are such issues with surgeons is they have to be precise, and surgical complications are a huge issue, especially infections, with like joint commission and with their numbers. So I'd love to talk more about, oh my God, dishing the dirt on doctors, but we can keep going, guys. So always use your leading zero. That way they're not misread as 0.25. Yeah, hey, sometimes it's just, how you say it. All right, so make sure you're using leading zero for decimal dosages. Some of you guys did not do this on the test, and you're only getting partial credit because that's huge. You can see how big of a difference in dosing 0.25 versus 25. Take your time to learn any special administration techniques with certain dosing forms, and always verify new medication with the orders and the record. If the patient has any concerns, make sure you're listening to them and honoring them. Make sure you're always checking your patient's allergies and their identification. So the nurse is administering a drug that has been ordered as Give 10 milligrams on odd number days and 5 milligrams on even number days. When the date changes from May 31st to June 1st, what should you do? A, give 10 milligrams because June 1st is an odd numbered day. B, hold the dose until the next odd numbered day. C, change the order to read give 10 milligrams on even numbered days and 5 milligrams on odd numbered days. Or D, consult the prescriber to verify that the dose should alternate each day no matter what day. Yep, it is D. You guys are right. So you call the prescriber and you would just say, hey, I know you ordered this on odd and even number days, but we're coming up on 2 odd days. So were you meaning to have it every other day? And if it's, oh yeah, every other day, then you could write the order, give 10 milligrams every other day, alternating 5 milligrams, 10 and 5 milligrams alternating, but somehow you would show that it would be every other. Okay. Give 10 milligrams every other day, alternating with 5 milligrams. Report errors. So make sure that you report it to the prescriber. You're going to have to call the doctor and say, oopsie. Your highest priority if there's an error is your patient. It's your patient's physical status. Your documentation, you need to document per policy. Again, this is not going to go into the patient's chart. This is like an incident report. Okay. You want to be accurate, thorough, and objective. Don't use judgmental words. Note the medication that was administered, the dose given, and any other details. Was it the wrong patient, wrong route, right time? Note any changes. Document prescriber was notified and any follow-ups. Continue to monitor your patient. And do not document in the patient's chart that an incident report was filled out, as we talked about. When you're in clinicals, if you make a medical error, you first come to your instructor. Okay. So you let your nursing instructor know, and then we will take it from there. Of course, we'll have to let the patient's nurse know, the charge nurse, and there will be an incident report. But yeah, first person you notify is your instructor. External reporting of errors, you have the United States Pharmacopoeia, MedWatch. MedWatch is where you report any adverse reactions by a drug. So this is actually for drug safety. Institute for Safe Medicine Practices, and of course, Joint Commission. Any member of the public can report problems with a medication or medical devices via the telephone, mail, or online at the MedWatch website. So, a nursing student realized that she's given a patient a double dose of an antihypertensive medication. Tablet was supposed to be cut in half, but the student forgot and gave the entire tablet. Let me tell you, I have done this, guys. It happens. Patient's blood pressure just before the dose was 146/98. What should you do first? A, notify the patient's physician. B, notify clinical faculty. C, take the patient's blood pressure. Or D, continue to monitor. Yes, guys, so this is a nursing student. That's the key. So the actual answer is B. Just said, notify your clinical faculty. So notify your instructor first, okay? Then we'll go through the rest of it. All of it is accurate, but the first thing you're going to do is let your instructor know. That's okay. Don't apologize, Sean. Pediatric errors. Most common med error in pediatrics happens in dosing. Which doesn't seem like it's, that seems definitely something that would be common. High-risk medication errors, higher risk ones include children under 2, those in intensive cares, the ER, highest risk of med errors between 0400 and 0800, so 4 and 8 in the morning, on a weekend, when they're receiving IV or chemo drugs, and if you don't have a weight. Very, very important, you guys, that you check weights, because most children's medication will be weight-based. So know your drugs, follow the 10 rights, avoid verbal orders as much as possible, avoid distractions. If you're pulling medications and someone's trying to talk to you, it's okay to say, "Oh, I'm sorry, I need to get these medications for my patient. Can I get these medications and then give them to my patient, and then we can talk, and then communicate with everyone." So when you're reconciling an order, you're going to continually assess and update medication. So verification is making sure you've looked at the patient's medication information with a focus on the medications they're currently using. Clarification, so make sure you've got the right information, the right med, and the right dose. And then reconcile, investigate any discrepancy or changes if needed. So the process in which you reconcile, you're reconciling at all points, okay? All points of entry, all points of exit. So the patient needs to give you a list of medications, including all the over-the-counters. And then the prescriber will look at that list and say what they're going to use in the hospital and what they're not. A lot of time, the supplements and herbals and multivitamins, they won't, depending on the condition, just because those aren't super duper important. Unless you're talking about, say, an alcoholic. Make sure there's no discrepancy between what the patient is taking and in the hospital. Now, that being said, sometimes they may change a dose based on the patient's condition. So if you have a patient with hypertension and they've been taking 10 milligrams of lisinopril and their blood pressure readings are still high, and that's part of why they're in the hospital, they may then increase the dose to 20 milligrams. Reconciliation should always be done at admission. Again, when there's any status change, when a patient is transferred within units or between facilities or provider teams. And then, of course, at discharge, the patient should be given a list of their medications to take with them. So, ethical issues. This one gets brought up a lot. Notifying patients when there's a medical error. Research actually indicates that notifying the patient helps healthcare organizations actually avoid litigation and potentially much larger financial settlements. As you know, the possible effects on the patient can be anywhere from nothing to potential death, and that could be very emotional, as Kristen brought up. Sometimes you'll be named as a defendant in malpractice litigation. You may have your own personal malpractice in addition to what your employer gives you. Make sure you have clear documentation of any institutional malpractice coverage, and then decide whether you want to carry your own malpractice coverage. I'm going to say this, guys, it's best if you carry your own in addition to, and then you also want to make sure that if you have malpractice insurance, it covers the lawyer, okay? Not all malpractice insurances cover legal fees. So very important that you should do that. Okay, so that's the end of chapter 5. And I'm going to have you guys take another little break for about 10 minutes. No. About 5 minutes. So be back at 2:35 and we'll try and get through this last chapter. Okay, I know, quick break. Sorry about that, guys. Learning objectives. First, drug therapy during pregnancy. So, of course, a lot of drugs cross the placenta. During pregnancy, the first trimester is the greatest period of danger for drug-induced defects. So again, the first trimester is the period of greatest danger. Factors that contribute to the safety or potential harm of the drug basically go down to drug properties, gestational age, and some maternal factors. Drug properties are the impact drug transfer to the fetus, including the chemistry, dosing, and anything concurrently. So like molecular weight, protein binding, solubility. Then gestational age, as I just said, the biggest risk is during the first trimester because you got a lot of cell proliferation going on. Self-treatment of minor illnesses is very discouraged during pregnancy. And you often use gestational age in determining when a drug can cross the placenta to the fetus. So the last trimester, third trimester, is when you have the greatest percentage of maternally absorbed drugs getting to the fetus. Which makes sense. The fetus is almost fully formed, and then, you've got more blood flowing through there. Other maternal factors are any changes in the mother's physiology, like kidney or liver function, genotype about how drugs are metabolized. Exposure of the fetus to drugs is most detrimental in first trimester. And drug transfer is most likely to happen in the last trimester. Okay. A lot of times the potential for harm outweighs the risk. And then you have your FDA classifications according to safety. And these are based on mostly animal studies, very few human studies. So those categories, you have category A, where studies indicate no risk. Okay. Category B, no risk to an animal fetus, but there's no information for humans. In other words, there have been no studies with humans. Category C, adverse effects on animal fetus. Again, no information on human. Category D, possible fetal risk in humans has been reported. However, in select case, the benefit may outweigh the risk. And then category X is pretty much do not use. Think of skull and crossbones. The crossbones forms the X. Fetal abnormalities reported. Positive evidence of fetal risk is in humans available from animal and or human studies and should not be used. Now, if you guys want to see this table, it is on page 37 in chapter 3 of the pharmacology book. So A, there's no risk. B, no risk to the animal fetus, but we don't know about humans. C, adverse effects in animals, but we don't know about humans. And then D, possible human risk, but the benefit might outweigh it. So, and we also have it divided into pregnancy, lactation, and then, of course, reproductive potential. When teaching a pregnant woman about the use of drugs during pregnancy, which statement will you include? A, exposure of the fetus to drugs is most detrimental during the second trimester of pregnancy. B, pregnant women must never take drugs to control high blood pressure. C, drug transfer to a fetus is most likely to occur during the last trimester of pregnancy. Or D, a fetus is at greatest risk for drug-induced developmental defects during the second trimester of pregnancy. It is C. Drug transfer is most likely during last trimester because of enhanced blood flow to the fetus, increased fetal surface area, and increased amounts of free drug in the mother's own circulation. Breastfed infants are at risk for exposure. A lot of drugs easily cross into breast milk and thereby to the breastfeeding infant. So some drug characteristics that increase that unlikelihood are fat soluble. Think about what milk is made up of. Low molecular weight, and then high concentrations. So characteristics that increase likelihood of transfer during breastfeeding: fat soluble, low molecular weight, and high concentrations. The actual amount of exposure actually depends on the amount of milk consumed or the volume. And of course, as always, you have to weigh the risk to benefit ratio, both to the mother and the baby. All right, classifying young patients. So if a baby is born and they're under 38 weeks gestation, they are considered premature or preterm. Any infant that is younger than 1 month is a neonate or newborn. 1 month to 1 year is an infant, and then 1 year to 12 is a child. And then after 12, it goes all downhill. No, I'm just kidding. So pediatric dosing may differ. A lot of times the max age for pediatric patients may be identified as 16. Different manufacturers have different guidelines. The other thing you need to look at the patient's pediatrics level, especially with tweens and teens. I'm 5'3", and I'm not going to tell you what my weight is, but we're just going to say I weigh 120 pounds. So if I have a 14-year-old girl who's 5'3" and 120 pounds, as a provider, I'm not dosing her as a pediatric patient unless there's a significant difference. If she meets, because she is the size of an adult, I'm going to dose her like an adult. So that's something also to kind of keep into consideration. So neonate and pediatrics. So pharmacokinetics, the absorption. Gastric pH is less acidic, so there's not as much acid until they're about 1 or 2 years old. Also, gastric emptying is slower. And intramuscular absorption is faster and more irregular. So consider that first pass elimination by the liver is decreased because the liver is immature and they don't have as many enzymes too. When it comes to it can, Mercedes, depending on the medication and also on the child. But not always. So think of someone who maybe has dwarfism. Well, they're an adult, but they're smaller, but you may have to adjust their medication. Whereas a child who might be bigger, some things, pediatric dosing up to age 16 is a little silly. I've run into 12-year-olds that were the same size as an adult, and I've had to actually adjust dosing. Obese pediatric patients might get a more adult dose of medication because of their body size. Where was I going? Oh, greater distribution of medications in the body. There's a greater total body water, so lower fat. In a full-term infant, the total body water is 70 to 80%. It's 85% in preterms and 64% in children ages 1 to 12. You also have a decrease in protein binding and an immature blood-brain barrier, so you get more drugs into the brain. Metabolism, again, metabolized, they don't get metabolized. The liver's not as mature. They don't have as many enzymes. Older children, of course, may have increased metabolism, so they're going to need higher than an infant. And then, of course, you've got some other factors and variables in there. Excretion, again, we're talking about organ immaturity. So kidney immaturity affects the filtration rate and tubular secretion. And then also the perfusion rate at the kidneys may decrease the excretion. So other factors, skin. Their skin is very thin and extremely permeable. So if you're using a transdermal, you might want to use a lower dose. The stomach does not have acid to kill bacteria. The lungs have weaker mucus barriers. Body temps aren't as well regulated. Dehydration occurs easily. And the liver and kidneys are immature, impairing metabolism and excretion. So method for calculating dose for PEDS patients, sometimes you'll do the body surface area, which is the West nomogram. Honestly, this isn't used that much that I know of. I haven't used it, but I don't work in PEDS a lot. But I can ask Professor Nosek, who does PEDS. Always, 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 when you're doing a child's weight, it will be in kilograms. So if you weigh them and you get it in pounds, you're going to have to convert it. It needs to be in kilograms. You're also generally going to use centimeters, not inches. And then body weight dose calculations. You're using milligrams per kilogram. This is the nomogram to determine body surface area. So you can see up here, you've got your height, you've got your weight. So if you knew how many inches the child was, so say 40 inches, and you can figure that out. You have to use a straight edge, ruler, paper, aligning boxes. It's very kind of complicated, and I think leaves a lot of opening for error, whereas just doing it by kilograms would be much better. General consideration, make sure you have all your equipment prepared. Infants, you want to maintain safe, secure positioning. So the parent might be holding them, especially if you're doing a procedure, make sure, like injection, make sure you're swift with it. And then allow self-comforting. If they need a pacifier, sucking their thumb, self-movement, whatever they need. Toddlers, you want to give a brief but very concrete explanation. Realistic expectations of their understanding. Parents might be part of the process, so they might have to hold the child. Accept aggressive behavior as a healthy response, but only within reasonable limits. Help the child understand the treatment and provide healthy ways to release aggression. Preschoolers, again, a brief, concrete explanation, provide comfort measures, use magical thinking, ointments and special medications to make discomfort go away. The role of the parent is to provide comfort and understanding. School age, again, explain the procedure, allow for some control. So if you have to give an injection, say, okay, well, I can give this injection in your arm or your butt. Where would you like it? Or your backside, whatever you want to say. And that allows them a little bit of measure of control. Make sure you provide comfort measures. Make sure you explore their feelings and concepts. Set age-appropriate behavior limits. It's okay to cry or scream, but it's not okay to bite me. Teach about the relationship between the medication and body function. And then adolescents, make sure you prepare them in advance, but without actually using scare tactics. Make sure you allow them to express themselves in a way that doesn't let them lose any face. So give them time alone after the procedure. And then any current concepts of self, any of those. Encourage self-expression, individuality, and self-care. And then also participation, especially with adolescents. All right, when administering medications to pediatric patients, the nurse understands that the dose calculations for pediatric patients are different than adults because pediatric patients are A, more likely to develop edema, B, have more stomach acid, C, have skin that is less permeable, or D, have immature liver and kidney function, resulting in impaired drug metabolism and excretion. Yep, exactly. D. They don't, immature liver and kidney function, immature organ function in general. Older adults. So we're talking about adults over 65. They use a lot of medication. They'll have polypharmacy, which is the use of multiple medications. That increases the risk for drug interaction. So for a patient who takes 5 medications, the chance of a drug interaction is 50%. And if they're taking 10 or more medications, that goes up to 100%. When you're dosing with adults, older adults, go low and slow. Okay. Then we have non-compliance and non-adherence. Occurs in about 40% of older patients. Could be due to not being able to afford the medications. Maybe they didn't understand the directions and those kinds of things. They have an increased incidence of chronic illness, so they're going to be on more medications. And then, of course, there's sensory and motor deficits. We're also going to make sure that you look at lab tests, so like liver function, so AST and ALT. Also kidney function, so the BUN and the creatinine. So, cardiovascular changes. GI. Elderly adults have increased pH, which makes it alkaline. They have decreased peristalsis, so the stomach doesn't empty as quickly. Decreased cardiac output, which decreases absorption and distribution because the blood's not flowing. Same thing, so decreased cardiac output, you get decreased blood flow. Hepatic, referring to their liver, you have decreased enzyme production, so things aren't metabolized. Decreased blood flow leads to decreased metabolism and also excretion. And then, of course, kidney function. Decreased blood flow decreases excretion, decreased function decreases excretion. So basically, any kidney problem is going to decrease the excretion. Absorption. Gastric pH is less acidic, so it's more alkaline. Okay. Gastric, as we talked about, slowing movement through the GI tract is slowed, blood flow, and decreased surface area. Okay. So as we age, the villi in our GI tract actually kind of flatten. So we have less surface area. So lower total body water, 40 to 65, it's 55 in males and 47% in females. In adults over 60, total body water is 52% in males and 46% in females. So the important thing is there's less body water. Fat content is increased because, we all gain a little weight. And then decreased production of proteins by the liver. So decreased protein binding of drugs. So you have increased circulation of the free drugs. Metabolism, the aging liver doesn't produce as many enzymes, and decreased blood flow. And then excretion, decreased glomerular filtration rate, decreased amount of nephrons. So it's decreased, your GFR, glomerular filtration rate, is decreased by up to 40 to 50%. And when we talk about decreased number of nephrons, we're talking about the ones that are intact. Okay. Problematic medications. These are some meds that require special considerations. Opioids, anticoagulants, especially if they're a fall risk. Anticholinergics cause a lot of dry mouth, blurry vision, urine issues. Antidepressants, antihypertensives. cardiac medications, central nervous system, sedatives, pretty much anything is on what's called the Beers list of criteria. Should I or shouldn't I use it? Basically, as I learned when I was practicing, pretty much if you're over 65, you shouldn't take any medications because they're all bad for you. That's what I learned. It's not true, but that's how it felt. So age, older adults medication administration, you want to look at their age, any allergies, their diet habits, any sensory deficits, financial status, any limitations, list of all health-related care providers, financial status and limitation. There's a lot of help out there. A lot of the drug companies provide assistance. The problem is a lot of those assistance programs they cannot use if they're on Medicare. That's a whole other ball of wax, but just wanted to point that out to you guys. You also want to look at medication, their list. Do they have polypharmacy? Do they follow safe medicine practices, labs, history, smoking, alcohol? And then, as I talked about, Beers criteria. So it's a list of potentially inappropriate medications for the use in individuals over 65. It's meant to help prevent adverse drug reactions. The only issue, the problem with Beers criteria is that so many medications have a potential for adverse reaction in over 65 that really, honestly, they should do the opposite. Okay, these are ones you can use as opposed to can't use. All right, what does the nurse identify as a pharmacokinetic change that occurs in older adults? A, gastric pH is more acidic. B, fat content is decreased because of increased lean body mass. C, there's an increased production of proteins by the liver. Or D, the number of intact nephrons is decreased. Oh, don't pick on Sean. It is D, correct. Good job, guys. And there's a class activity, but we're running short on time. So I am going to, you guys have a paper coming up. So I figured we'd go over that real quick. Not sure. Oh, I suppose I could share that with you. Whoops. Let me share. Back to where I was. Sorry, guys. Week 3. Case study, do week 6. Okay. So it's due by Sunday. So read the scenario, answer the questions listed. When answering questions, you will need to include the following. A disease process description. A disease process description is included with a credible reference. So, again, you guys can use the nursing diagnosis book has a lot of good disease process information in there. Your medical surgical book. No, Haley, this is due in week 6. Your medical surgical book has disease processes. Problem accuracy. All of the problems are included accurately in per NANDA standards. Okay, so we're talking about, I thought I called you Hayes. So when you're writing your nursing problems, intervention should be patient-centered and supported by your assessment. And then rationales. Why are you doing what are you doing? Again, your nursing diagnosis. APA references, make sure you're using in-text citation appropriately and provide a reference list that is formatted in APA format. Whoops. I really don't need you guys to see all that, so we'll just go to here. No, you can't have the answers. Okay. That's not me. MG is a frequent flyer. What error in teaching most likely occurred when MG was discharged? Okay. So I want you to think about teaching that should have occurred when this patient is discharged. What did they not teach the patient, or what was missing, or what did they teach and he didn't listen? Who knows? Okay, then you got your medications. Which may have contributed? So you're going to have to look up these medications. How do angiotensin converting enzymes work to reduce heart failure? This is a multi-choice question. Select all that apply. What is the rationale for changing the route of the furosemide, Lasix? You administer furosemide. Identify 3 parameters that you would monitor. What lab test should be ordered for MG related to the order for furosemide? Okay. Use your pharmacology and the nursing process textbook. What is the purpose of the beta blocker carvedilol? What is the action of digoxin? Which finding from MG's assessment would indicate an increased possibility of digoxin toxicity? When you go to give digoxin, you notice that it is available in milligrams and micrograms, so do the math and convert it. So basically, you're just going through and answering all these questions. But then you have to use APA format and make sure you're doing correct citation. So these, I would recommend that you use your pharmacology and the nursing process book, perhaps even your nursing diagnoses textbook too. And then the grading rubric is, very similar, but I'm actually able to, I would prefer they are typed, Courtney, if at all possible. And yes, that's how it's supposed to look, Jessica. I would prefer it be neatly done, typed up with appropriate sources. So you guys aren't going to actually get this because I have this in the system. So when you upload it, the system has this rubric in there. But make sure you're using your NANDA accuracy, so your nursing diagnosis book and all those things. And make sure you're justifying your rationales. Now, again, this is week 3, and this is not due until week 6. So it is due, June 1st. Yes. So it's due June 1st. You can write on this sheet, try and do APA. I don't want APA format for multiple choice. Yes, it's in here, Adriana. It's right there. I'm just letting you know that that rubric is built in. No. Absolutely, Mercedes. So if you're answering a question and you're using your book, and you're citing the source, like what is the purpose of digoxin, I want you to make sure you cite your source. What's the purpose of digoxin? Don't forget, guys, I want to say 30. Let me double check. No, Jessica, no title pages. 1, 2, oh, 40. 40 points. No abstract, Adriana. By APA format, I want you to cite your sources, APA. So for some of these questions, the way you're going to answer it, you're going to need to utilize no footnotes. Unless you want, Emily, it's appropriate for that particular thing. But the structure and citation needs to be done in APA format. We'll get more APA in your other class. What paper, Christina? Are you talking about the one for fundamentals? Okay, no, that is. Hang on. No, the one for fundamentals or 130 is due during lecture 6. So that is due May 14th. So your paper for fundamentals is due May 14th. And this case study is due June 1st. Yes, ma'am. I believe it was 2 weeks ago, Veronica, you brought it up, or a week ago. And we discussed this paper. No, it says lecture 6. Last week. Thank you, Shanae. Two and a half, Natalie. Not including your reference and title page. Very important, Christina. And that's why I did it, Veronica, because of the fact that we are not doing week by week. So, because my lecture, week 6 is lecture 6, which you're having Thursday. So that's why it's tricky. I tried to make as much sense of it as I could by making sure the dates were in as much as possible. So if you want to know when things are due, definitely utilize the syllabus and the modules. So when you're in here, guys, so the modules. So lecture 1 was Tuesday. Lecture 2 was a Thursday. Everything in here has its due dates when you know when it's due. If you need to, I suggest, whiteboard calendar. I know, Veronica, I'm very sorry. I know you guys, this is very frustrating to you. It's meant to help you understand the content better. So that being said, in 3 weeks, your case study is due for 140 since that's what we're teaching today. Everything's there for you. If you have a problem with any of those links, like they won't let you in, let me know. So I can fix those, but I think they should be set to go. We got through the lecture today. I recommend chapter 3 rapid practice problems. And I will do my best to try and get your test grades by Friday. Yeah, I have a planner and a calendar going, guys, so I can keep track of both classes all the time. So trust me, it's I know it's hard for you. It's not always easy for me. So all right, you guys. So everybody, I will see you tomorrow morning, bright and early. Well, not really 8:30. That's not that early. There are a couple of you who had issues with Respondus, so we're gonna go ahead and do the class or do the quiz now for you. Everybody else, you guys have a great evening. Sorry I stressed you out. But at least you guys didn't find out you had your paper due tomorrow, that find out tomorrow that your paper was due by Thursday. I may extend it to Sunday. So if you ask nicely. Anyways, you guys have a great rest of your evening. And the couple who had issues with Respondus, you guys just go ahead and stay here. And we'll get you guys into the quiz. Oh. And I should probably stop screen sharing.